A 79-year-old retired contractor named Gerald spent 4 days in a hospital bed in Raleigh, North Carolina. He received intravenous medication, he underwent cardiac testing, he had blood drawn twice a day. A cardiologist visited each morning, nurses checked on him through the night. By any reasonable definition of the word, Gerald was a hospital patient. He looked like a hospital patient, he was treated like a hospital patient, and he believed, completely and reasonably, that Medicare would cover his stay the way Medicare covers hospital patients. 2 months later, a letter arrived that his wife read 3 times before she believed what it said. Because of a single hospital rule Gerald had never heard of, a rule that appears nowhere in Medicare's standard materials, a rule that no one mentioned during his 4-day stay, a rule that is entirely legal and entirely invisible to most patients, Gerald owed $17,800, not for negligence, not for uncovered services, for a classification decision made inside the hospital's billing system that Gerald had never been told about and had no idea he could question. His wife said, "We have done everything right our entire lives. We paid into Medicare for 40 years. We followed every rule we were ever told about. And then someone told us there was a rule we had never heard of, and it cost us everything we had saved for 3 years." If you are on Medicare, or if someone you love depends on Medicare, what you are about to hear could be the most important financial information you receive this year. Today, we are going through 5 hidden hospital rules that most seniors never hear about, rules that create unexpected bills, denied coverage, and financial consequences that blindside families at the worst possible moments. For each rule, you will learn exactly what it means, exactly what it can cost, and the exact words you need to say to protect yourself before that rule is used against you. We are counting down from 5 to 1. Stay with me through all 5, because the number 1 hidden rule on this list is the one that causes the largest unexpected bills, affects the greatest number of Medicare beneficiaries, and is almost never explained by anyone inside the hospital whose job it is to explain it. Let us begin. Most seniors who spend a night in the hospital assume one thing about that night. They assume it counts. They assume it counts toward Medicare coverage, counts toward the 3-day inpatient requirement for skilled nursing care, counts as the kind of hospital stay that protects them financially in the weeks that follow. The first hidden rule says that assumption may be completely wrong. It is called the observation status rule, and it works like this. When a hospital decides that your condition requires monitoring, but does not yet, in the clinical and billing judgment of the facility, clearly meet the criteria for formal inpatient admission, they may classify you under observation status. Observation status is a billing classification. It designates you in Medicare's accounting as an outpatient, not a visitor, not someone waiting for a room, an outpatient, receiving outpatient-level coverage, regardless of what your care actually looks like. Under observation status, Medicare Part A does not cover your stay. Your prescription medications may be billed to you directly at hospital retail prices because outpatients are expected to bring their own medications from home. And the days you spend under observation status do not count as inpatient days for any purpose, including the 3-day inpatient requirement for skilled nursing facility coverage after discharge. The deepest frustration for most families is not just the financial consequence. It is the invisibility of the classification itself. A patient under observation status looks exactly like an inpatient. They are in a hospital bed. They receive nursing care around the clock. They wear the gown. They receive the meals. There is no sign on the door that says outpatient. There is no bracelet with a different color. There is nothing visible that signals to a patient or their family that the rules governing this stay are fundamentally different from what they assume. Vera was 77 years old, a retired office administrator from Louisville, Kentucky. She was brought to the hospital after experiencing dizziness and balance problems that her family feared might be stroke-related. She was kept for 3 nights while testing was conducted. Her husband visited every day. The nursing staff was attentive. The tests ultimately showed no stroke. When Vera was discharged, her physician recommended a short stay in a skilled nursing facility for balance rehabilitation. Her family arranged it gratefully. They believed Medicare would cover it. At the skilled nursing facility, the admissions coordinator reviewed Vera's hospital records and asked the question that changed everything. She asked whether Vera had been admitted as an inpatient. She had not. She had been under observation status for all 3 nights. Medicare denied skilled nursing coverage entirely. The rehabilitation facility charged private pay rates. Vera's bill for 2 weeks of rehabilitation was $14,600. Her husband said she was in a hospital bed for 3 nights. She had nurses checking on her every few hours. How is that not being in the hospital? Nobody told us there were 2 different ways to be in a hospital. Here is what you must do on the very first day of any hospital stay. Do not wait for discharge. Do not wait until the skilled nursing question comes up. On day 1, ask the attending physician or charge nurse this question directly. Ask, is my loved one currently classified as an inpatient under Medicare Part A or under observation status as an outpatient? And if it is observation status, I would like to understand the clinical reason that admission criteria are not met. Write down the answer. If the answer is observation status, request immediately to speak with the hospital's patient advocate and ask them to document a formal physician review of the admission classification. That conversation on day 1 gives your family real options. The same conversation on day 4, at discharge, gives you almost none. The observation status rule is invisible by design. You now know to look for it. Look on day 1. Most families who fall into the observation status trap discover a second rule immediately afterward, a rule that closes the door to the coverage they needed most. And this second rule, once triggered, is extraordinarily difficult to reverse. It is called the 3-day inpatient rule, and it is one of the most consequential and least understood requirements in all of Medicare. Here is how it works. To qualify for Medicare-covered skilled nursing facility care after a hospital stay, the rehabilitation care, physical therapy, occupational therapy, and skilled nursing support that many seniors need after a serious illness, surgery, or injury, Medicare requires that you have been formally admitted as a hospital inpatient for at least 3 consecutive calendar days. Not 3 days of care, not 3 nights in a hospital bed, 3 days of formal inpatient admission, classified as such in Medicare's billing system, not counting the day of discharge. If your hospital stay was shorter than 3 days, or if any portion of your stay was classified as observation status, or if you were admitted and discharged in a pattern that did not accumulate 3 qualifying inpatient days, Medicare will not cover your skilled nursing facility stay. Not at a reduced rate, not with a higher deductible, not at all. And the cost of a skilled nursing facility stay without Medicare coverage is not a small inconvenience. It is a financial event. Private pay rates at skilled nursing facilities average $8,000 to $10,000 per month. A 4-week rehabilitation stay paid entirely out of pocket can equal an entire year of Social Security income. Raymond was 82 years old, a retired pharmacist from Orlando, Florida. He had knee replacement surgery that went smoothly. His surgeon recommended a 10-day skilled nursing facility stay for rehabilitation. Raymond had Medicare and a strong supplemental plan. His family anticipated minimal out-of-pocket costs. What they did not know was that Raymond's surgical stay had been classified as an outpatient procedure under a same-day surgery designation that did not generate any inpatient days, followed by 1 night of observation status monitoring. He had 0 qualifying inpatient days. Medicare denied skilled nursing coverage entirely. Raymond's 10-day rehabilitation stay cost $22,000, paid from savings he and his wife had set aside over 20 years for their grandchildren's education. His wife said his surgeon recommended the rehabilitation. The facility was wonderful. The care was exactly what he needed. And Medicare said it would not pay a single dollar because of something that happened in the billing office, not in the operating room. Here is what you need to do before any planned procedure or hospitalization. Contact your Medicare plan and your surgeon's office and ask these specific words. Ask, will this procedure generate at least 3 qualifying inpatient days under Medicare Part A? And if there is any possibility that it will not, what are my options for ensuring the 3-day inpatient requirement is met before I need skilled nursing facility care? That question, asked before the procedure, sometimes reveals that surgical scheduling or admission planning can be adjusted to protect your Medicare coverage for rehabilitation. The same question asked after the procedure, when you are already in the skilled nursing facility, has no good answer. This rule has surprised more Medicare beneficiaries than almost any other single requirement in the program. You now know it exists. Ask about it before you need to rely on it. But even when inpatient status is secured and the 3-day rule is met, there is a third hidden rule that can still block the coverage seniors expect for treatments, procedures, and services they never imagined would require advance approval. And this rule operates silently. Most seniors do not know it has been triggered until the service has already been provided and the bill has already been sent. It is called the prior authorization rule. Medicare Advantage plans, the private plans through which more than half of all Medicare beneficiaries now receive their coverage, are permitted to require prior authorization for certain procedures, specialist visits, medications, and post-acute care services. Prior authorization means that before a service is provided, the insurance plan must review and approve it in advance. The challenge is that prior authorization requirements are not always clearly communicated to patients. A physician may order a service. The hospital or specialist may schedule it. The patient may receive it. And only when the claim is processed does the patient learn that prior authorization was required and was not obtained, and that the plan will not pay for the service as a result. The financial exposure created by a failed prior authorization can be significant. Services that Medicare Advantage plans may require prior authorization for include certain surgeries, MRI and other imaging services, skilled nursing facility stays, home health visits, and chemotherapy. Each of these represents a potentially large cost if the claim is denied. Loretta was 73 years old, a retired nurse from Seattle, Washington. She was enrolled in a Medicare Advantage plan and was scheduled for a surgical procedure that her physician had determined was medically necessary. The physician's office submitted the procedure for scheduling and assumed that authorization would be handled through the standard referral process. A miscommunication between the physician's billing staff and the insurance plan resulted in the procedure being performed without a completed prior authorization. The plan denied the claim. The procedure cost $11,400. Loretta received that bill 8 weeks after her surgery. She spent 4 months appealing the denial. The appeal was ultimately partially successful, but the process consumed hundreds of hours of her family's time, caused enormous stress, and resulted in Loretta paying $2,600 she had not budgeted for a procedure her own doctor had ordered. She said, "I was a nurse. I knew about prior authorization. I thought my doctor's office had handled it. I did not know I needed to verify it myself." Here is what you must do before any scheduled procedure, specialist visit, or post-hospital service if you are on a Medicare Advantage plan. Call your insurance plan directly, not your doctor's office, but your insurance plan, and say these words. Say, "I have a procedure scheduled with this provider on this date. I need to confirm that prior authorization has been obtained, approved, and documented on my account before that procedure takes place." Do not assume your doctor's office has handled it. Verify it yourself. Get the authorization number. Write it down. Call again the day before the procedure if there is any uncertainty. Prior authorization denials are one of the most common sources of unexpected medical bills for Medicare Advantage enrollees. The protection against them is a single phone call made at the right moment. Make that call every time. Have you ever received a hospital bill or Medicare denial that completely surprised you? Tell us in the comments. Your experience could help another senior know exactly what to look for before they face the same situation. The next hidden rule moves away from insurance classifications and coverage requirements and into something that happens inside the hospital itself. Something that most seniors experience during every hospital stay, without ever knowing it is happening or what it means for their bill. We have discussed independent physician billing in previous videos, but the hidden rule that makes it so financially dangerous goes deeper than most families realize. Here is what most seniors do not know. When a physician treats you inside a hospital, they may be what is called a hospital-employed physician, someone whose compensation comes from the hospital and whose billing is managed through the hospital's billing system. Or they may be an independent physician, someone who is credentialed to practice at the hospital, but who operates as a separate business entity, employs their own billing staff, negotiates their own insurance contracts, and sends their own invoices entirely independently of the hospital. The distinction matters enormously because an independent physician at an in-network hospital may themselves be out-of-network. Their insurance contracts are negotiated separately, their network status must be verified separately, and their bills arrive separately, sometimes weeks after the hospital bill has been paid and closed. The hidden rule is this: the hospital's network status does not determine the physician's network status. They are two entirely separate determinations, and no one is required to tell you this during your stay. Stanley was 76 years old, a retired school principal from Detroit, Michigan. He was treated at a hospital his Medicare Advantage plan fully covered. His primary surgeon was in-network. The facility was in-network. He had verified both before the procedure. During his 3-day stay, he was seen by a hospitalist physician who managed his overnight care. He was visited by a consulting cardiologist called in by a surgeon. He had anesthesia provided by a member of an independent anesthesiology group. All 3 of these physicians billed independently. All 3 were out of network with Stanley's plan. The hospitalist group billed $2,200. The cardiology consultation billed $4,100. The anesthesiology group billed $9,800. Stanley's combined out-of-network exposure across all 3 bills was over $16,000 for physicians he had never chosen, whose network status he had no way of knowing, practicing at a hospital he had specifically verified was covered. His daughter said he did his homework. He checked the hospital. He checked his surgeon. Nobody told him that the other doctors in the building operated under completely separate rules. Here is what you need to say to the hospital before any scheduled procedure, during the admissions process, and to your insurance plan after any hospitalization. Before a procedure, say these words to your surgeon's office and to the hospital's patient services department. Say, I need a list of every physician category that may be involved in my care, including hospitalists, anesthesiologists, radiologists, pathologists, and any consulting specialists. I need to verify the network status of each independent group with my insurance plan before my procedure date. Then, call your insurance plan and give them that list. Ask them to run a network check by physician group name. It takes time, it requires persistence, but the protection it provides is worth far more than the time it costs. The independent physician billing rule is not a loophole. It is not an error. It is a structural feature of hospital billing that most seniors encounter without knowing it exists. You now know it exists. Verify every physician separately before every procedure. We have now arrived at the hidden rule that creates the largest bills, generates the most devastating Medicare denials, and affects a greater number of Medicare beneficiaries than any other rule on this list. It is a rule that operates not at the moment of admission, not at the moment of billing, but inside the medical documentation of your care. And most seniors never know it is happening until months after their hospital stay has ended. It is called the Medical Necessity Documentation Rule, and understanding it may be the single most valuable thing you take away from this video. Here is how it works. Medicare does not pay for hospital services simply because a physician ordered them or because a patient received them. Medicare pays for hospital services that are documented as medically necessary, meaning that the medical record clearly supports, in the language and specificity that Medicare's reviewers require, that the services provided were necessary for the diagnosis and treatment of the patient's condition. Medical necessity is not determined by how sick you felt. It is not determined by what your physician believed was required. It is determined by what is written in the medical record, by the documentation, the clinical language, the specificity of the physician's notes, and how well that documentation matches Medicare's established criteria for coverage. When the documentation is thorough and specific, Medicare pays. When the documentation is vague, incomplete, or uses language that does not clearly meet Medicare's criteria, even when the care itself was genuinely necessary, Medicare may deny the claim. The patient receives a bill for care that was absolutely required for their health, provided by physicians who are absolutely certain it was necessary, at a hospital that is absolutely in-network. And the reason Medicare denied it is a documentation gap inside a medical chart that the patient never saw and would not have known how to influence. This rule affects both hospital stays and outpatient services. It is the basis for a significant portion of all Medicare claim denials, and it is the rule that can generate the largest unexpected bills because it applies to the entire scope of inpatient care, not just a single service or a single visit. Agnes was 81 years old, a retired librarian from Nashville, Tennessee. She was hospitalized for a worsening heart condition and spent 6 days receiving treatment that her cardiologist considered essential. Her family was present throughout. Her physician was experienced and confident in the care provided. 8 weeks after Agnes was discharged, Medicare sent a denial notice. A Medicare contractor had conducted a post-payment review of her claim and determined that the documentation in her medical record did not sufficiently establish medical necessity for 4 of her 6 inpatient days. Medicare demanded repayment of a portion of the funds already paid to the hospital. The hospital, in turn, billed Agnes for the denied portion under the financial responsibility agreement she had signed at admission. The bill was $12,300. Agnes's son spent 5 months navigating the Medicare appeals process, working with a patient advocate and gathering additional documentation from her cardiologist. The appeal was ultimately successful at the 3rd level of review, but the process took nearly a year, and Agnes, then 82 years old, lived under the weight of that bill for every month of that year. Her son said, "My mother was genuinely sick. Her doctor is one of the best in the city. The care was real and it was necessary. But because of the way the notes were written, Medicare said they could not confirm it. I did not know that was possible. I did not know the notes were that important." Here is what you can do to protect yourself from this rule, both before and after a hospital stay. Before any planned hospitalization, ask your physician these words. Say, "Can you confirm that your documentation throughout my stay will clearly establish medical necessity for each day of inpatient care and each significant service in Medicare's required language so that I am protected against post-payment review denials?" Most physicians are familiar with medical necessity documentation requirements. Asking this question signals that you are an informed patient and that documentation quality matters to you. It may prompt a more thorough approach to charting throughout your stay. If you receive a Medicare denial after a hospital stay, whether it arrives as an initial denial or as a result of a post-payment review, say these words immediately. Say, "I want to formally appeal this denial through Medicare's appeals process. I need the specific documentation deficiencies that were cited in this denial so that my physician can provide supplemental documentation to support the appeal." Then, contact your physician's office immediately and share the denial notice. Your physician's supplemental letter documenting medical necessity, submitted as part of your appeal, is the most powerful tool available in reversing a medical necessity denial. Many of these denials are overturned when supplemental physician documentation is provided. Do not accept a medical necessity denial as final. The appeals process exists specifically for situations like this, and the success rate for Medicare appeals, when properly supported, is significantly higher than most beneficiaries expect. Before we close today, here is your Hidden Hospital Rules Protection Plan, the exact words that can protect you from every rule we have covered. For observation status, ask on day 1, is my loved one currently classified as an inpatient under Medicare Part A or under observation status as an outpatient? And if it is observation status, I would like to understand the clinical reason that admission criteria have not been met. For the 3-day inpatient rule, ask before any procedure. Will this hospitalization generate at least 3 qualifying inpatient days under Medicare Part A? And if not, what are my options for ensuring the 3-day requirement is met before I need skilled nursing coverage? For prior authorization, call your insurance plan and say, I need to confirm that prior authorization has been obtained, approved, and documented on my account before this procedure takes place. For independent physician billing, say to your surgeon's office and your insurance plan, I need a list of every physician category involved in my care, and I need to verify the network status of each independent group before my procedure date. For medical necessity documentation, ask your physician, can you confirm that your documentation throughout my stay will clearly establish medical necessity for each day of inpatient care in Medicare's required language? Write these down. Keep them with your Medicare card. Share them with the family member who will be with you during any hospital stay. Because these rules do not announce themselves. They do not come with warning labels. They operate inside a system that was not designed to explain itself to patients. You now understand rules that most Medicare beneficiaries never hear about until they are already dealing with the consequences. That knowledge, used at the right moment, is the most powerful protection available to any senior inside the American healthcare system. If videos like this help you protect your health, your finances, and your peace of mind, please subscribe and join us. We are here every single week because this information matters and because you deserve access to it before you need it. Because in our next video, we are answering the question that comes up more than any other from our community. Why do so many seniors receive bills they never expected, for care they thought was covered, from providers they never chose? The answer involves a set of billing practices that are completely legal, almost never explained, and entirely avoidable once you understand exactly how they work. You will not want to miss it.